Chapter 25: Suicide and Non-Suicidal Self-Injury. A suicide attempt is engaging in potentially self-injurious behavior with the intention of death. These attempts may be a result of death, injury, or no injuries at all. Suicidal ideation is thinking about killing oneself, whereas a suicide attempt is engaging in that potentially self-injuring behavior with the intention of dying. A non-suicidal self-injury is intentionally damaging one's own body without a conscious suicidal intent, such as cutting, self-harming. And suicide is that intentional act of killing oneself by any means. Suicide is the 10th leading cause of death for all age groups in the United States. It is the second leading cause of death for those aged 10 to 34, the fourth leading cause of death for those 35 to 54, and the age-adjusted suicide rate from 1999 through 2017 has increased by 33%. For males, the suicide rate increased 26% between 1999 and 2017. Of significance for females, the rate increased by 53% during that same time frame. White males accounted for almost 70% of all suicide deaths. Gino, aged 14, identifies as transgender, saying, "I have known since I was real little that I was meant to be a girl. I'm a girl on the inside and always have been. As soon as I'm of age, I'm going to get surgery for gender reassignment. I've been saving my money for it for as long as I can remember. In the meantime, I ask my friends to call me Gina instead of Gino. I grew up with these same kids, so my friends, it's really no big deal." This year, however, things have changed a bit for Gina. Growing up in a small neighborhood school in the city, she has now entered a new, larger school. She doesn't always have classes with her friends, and she's beginning to get pushed around in the halls. Recently, Gina, who dresses and grooms herself as a girl, tried to use the girls' bathroom, which was allowed at her small private school, but here a teacher followed her in and shooed her back out, calling it disgusting. 46% of those who die by suicide have a diagnosed mental illness, such as depressive disorder, substance use, or psychosis. Other risks for suicide include anxiety disorders, personality disorders, eating disorders, or other trauma-related disorders. Treating the coexisting psychiatric disorder may help most patients with their suicidal ideation. Let's start with risk factors. Let's start with the biological factors. There are familial tendencies, where it is higher among twins, and also corresponding with low serotonin levels. It also ties in closely with many of our psychological theories we discussed in the first week, such as Freud and his aggression turned inward, Menninger's 3 parts of a suicide hostility, which is a wish to kill, wish to be killed, and wish to die, and Aaron Beck, that central emotional factor is hopelessness. Can also have many environmental factors, such as family conflicts, low parental monitoring, and clusters of suicides, meaning a contagion or copycat suicides, whereas teens at the highest risk due to immature prefrontal cortexes, when one student kills themselves at a school, it increases the risk for the other students in that population. Adolescents are at especially high risk due to their immature prefrontal cortexes, the portion of the brain that controls that executive functions involving judgment, frustration tolerance, and impulse control. There are other cultural factors that could be at play, such as religious beliefs, family values, sexual orientation, gender identity, bullying behavior, and attitudes towards death. Other contributing social factors could be relationship problems, recent or imminent crises, substance use, health problems, financial problems, legal problems, and loss of housing. Other risk factors include that family history of suicide, a family history of child maltreatment and adverse childhood events, previous suicide attempts, a history of mental disorders, particularly clinical depression, alcohol and substance use, feelings of hopelessness, impulsive or aggressive tendencies, or again, those cultural and religious beliefs surrounding suicide. During the assessment, be alert for both verbal and nonverbal clues, such as overt statements, covert statements along with nonverbal cues, the lethality of the suicide plan itself, asking for a history of attempts, family history, a sudden switch from sad to happy mood, and social supports. That lethality of the suicide plan is especially key. The more lethal the plan and the more specific the plan, the more likely the patient was to follow through with it. Discussion. You're worried about a close friend who recently broke up with a boyfriend. She's taking the breakup very hard and seems depressed. What are some questions you could ask to assess for suicidal ideations? Questions like, have you ever felt that life was not worth living? Have you ever been thinking about death recently? Do you ever think about suicide? Have you ever attempted suicide? And do you have a plan for completing suicide? A suicidal patient can be very difficult for you as the caregiver as well. Health professionals may experience fear, grief, anger, puzzlement, and acknowledge feelings to team members to avoid countertransference. It can be a very sad situation watching someone go through that. Some appropriate nursing diagnoses would be risk for suicide, self care deficit, impaired sleep, impaired nutritional intake, or anxiety. The plan of care for the patient with suicidal ideation is based on risk and protective factors. When there is a comorbid psychiatric disorder, the treatment plan includes appropriate nursing approaches. For implementing our interventions, we can think of psychosocial interventions, health teaching and health promotion, including prevention efforts, case management, that milieu therapy, documentation of care, speaking with suicide survivors post prevention, and evaluation and an ongoing evaluation. Creating a safe environment is going to be key. Use and count plastic utensils. Make sure that they don't have a private room and keep the door open at all times. Provide jump-proof and hang-proof bathrooms. Lock doors to non-patient areas. Monitor for and remove potentially harmful items. And in patient's presence, assess belongings and search the patient for any harmful objects. And ensure the patients do not bring or leave any harmful objects. We actually had a very difficult situation, again, working in pediatric psych, where a young teenager had a wrist brace on. But that wrist brace came with a large piece of metal in it. And it took a lot of work and collaborating between both the orthopedic side, the medical side, along with the psychiatric side, because unfortunately that brace was a piece of metal, but it was also medically necessary. And just getting everybody on the same page until we were able to finally find a brace that wasn't a weapon on our unit, but could still provide the support to that patient's wrist that she needed. There can be a wide variety of treatment modalities, from biological treatments such as pharmacotherapy, medications for the comorbidities, brain stimulation therapy to decrease their ideation, as well as those psychological therapies and advanced practice roles. The Psychiatric Mental Health Advanced Practice Registered Nurse may treat patients with suicidal ideations directly with psychotherapy, psychobiological interventions, clinical supervision for direct care staff, or consultation in non-psychiatric settings. Following hospitalization, the advanced practice RN may provide aftercare for the patient who has coexisting psychiatric disorders. This care includes individual and family therapy along with medication management. Going back to our case study, Gina is hospitalized for suicidal ideation after 2 suicide attempts. For the first 2 days of hospitalization, the patient eats 20% of meals and stays in her room between groups. By the 4th day, the nurse observes that the patient is more sociable, is eating meals, and has a bright affect. Considering Gina's behavior on the 4th day of hospitalization, which factors should the nurse consider? A. The patient is showing improvement and may be ready for discharge. B. The patient may have decided to commit suicide. The nurse should reassess suicidality. The patient is feeling rested, supported in the therapeutic milieu, and less depressed. Or D. The patient is benefiting from the antidepressant she's been taking for 4 days. And the answer here is B. The patient may have decided to commit suicide. The nurse should reassess suicidality. Often they talk about dramatic mood changes being a high risk factor. That includes sudden upswings in the mood, and it is always wise to consider the possibility that a patient who is recently suicidal may be exhibiting positive traits because he or she is at peace with a final suicide decision and is feeling relief or even exhilaration about this. Do not just assume that they are immediately better until you've had more time to observe. For non-suicidal self-injuries, they usually come with a comorbidity of other mental health disorders and have a lot of risk factors from biological, cognitive, environmental, and social factors. Between 6% to 23% of the U.S. population engage in these behaviors at some time in their life. About 15% of adolescents and 17 to 35% of college students engage in self-injurious behavior. This peaks between 20 to 29 years of age and declines in early adulthood. The ratio of females to males with this disorder is about 3 to 1 or 4 to 1. When applying the nursing process, don't forget the importance of empathy. Look for triggers, and don't forget that self assessment of yourself as well for transference and countertransference. For our nursing diagnoses, identify that risk for self mutilation. And for outcomes, you're helping the patient with coping, identifying coping skills, identifying social supports, and helping them to adhere to that safety plan. When planning, use the 6-step approach, such as limiting the setting for safety, developing the patient's self esteem, discover the motive and its role that played in their previous ideations, discovering self control, replacing it with coping skills, and entering that maintenance phase. During implementation, make sure to care for the patient's injuries, establish that therapeutic alliance, teach coping skills, and promote reflective dialogue. In the case of injuries, our first priority is going to be ABCs, saving the patient. Then we want to assess the wounds, clean the wounds, make sure we're carefully documenting those wounds. And we want to continue to evaluate the patient's communication and perceptions. This is not going to be an instantly cured situation. It is going to be a long, ongoing process. Again, speaking of pharmacotherapy, comorbidities, and the advanced practice roles. That advanced practice psychiatric mental health MP may work with patients who use self-injury to cope. Specific therapies that are used include cognitive behavioral therapy, dialectical behavioral therapy, and group therapy. And finally, which method of suicide has the highest lethality? A. Ingesting pills. B. Cutting one's wrists. C. Inhaling natural gas. Or D. Self-inflicted gunshot wound. And that answer here is going to be D, a self-inflicted gunshot wound. By defining lethality, a self-inflicted gunshot wound is considered a high-risk method or hard method. The other examples listed here are lower risk or soft methods. Anyway, that is the last chapter we got in this slides. Suicide is a very tough situation, and if you go on working in mental health after graduation, it's unfortunately a situation you're going to have to deal with a lot. There are a lot of patients out there who have thought about suicide, attempted suicide, and it really does take a lot of empathy and a lot of strength on you as the nurse to be able to reach and help this patient and deal with that difficult situation. Anyway, that's all we've got here. I'll see you in the next slides.